Stop everything you are doing right now. Raise your right arm, straight up, as high as it will go. Now your left. Is there a difference? Does one arm stop at 90 degrees, shoulder height, while the other continues to the ceiling? Does the limited arm produce a deep, aching resistance at a specific point in the arc? A resistance that is not just tight muscle, but something deeper, something structural, something that feels like the shoulder itself is refusing to open. That resistance is your shoulder capsule. The joint capsule, the fibrous envelope that surrounds your glenohumeral joint, has developed adhesions, areas where the capsule has stuck to itself, folded upon itself, lost the slack it needs to allow the ball of the humerus to move fully through the socket. When you try to lift your arm and feel that deep, aching wall at 60 or 80 or 90 degrees, you are hitting the end of what your capsule currently allows. This is adhesive capsulitis, frozen shoulder. And your doctor may have told you what doctors tell most patients with frozen shoulder, that it is self-limiting, that it will eventually resolve on its own in 12 to 24 months, and that the management options are cortisone injections, physical therapy, or waiting. They may have told you to be patient. What they almost certainly did not tell you, because the technique is taught in specialized sports medicine and manual therapy training rather than general orthopedic practice, is that a specific movement performed in a specific way for 4 minutes every morning creates targeted mechanical stress on the inferior capsule and the axillary recess, the specific area of capsular restriction that limits arm elevation, and produces measurable capsular stretching and adhesion release within days rather than months. This movement is called the pendulum exercise, or Codman's pendulum, but the version I am going to teach you is not the passive pendulum most physical therapists demonstrate. It is a neurologically loaded pendulum that adds a specific rhythmic traction component that creates the intra-articular pressure change responsible for capsular distension and adhesion release. The difference between the standard pendulum and this loaded version is the difference between the exercises that produce modest improvement over months and the technique that produced Margaret's full arm elevation in 14 days. Margaret is 72 years old. Her frozen shoulder had been present for 11 months. She could not raise her affected arm above 60 degrees, not with pain, not without it. She had received 2 cortisone injections that had temporarily reduced the aching quality of the pain without restoring her range of motion. She had attended 6 weeks of standard physical therapy with modest progress that had stalled. She did this one move every morning for 14 days. On day 14, her orthopedic surgeon measured her range of motion at her scheduled follow-up. Forward flexion, full 175 degrees. External rotation, 40 degrees, near normal. He compared it to his notes from 3 weeks prior. He said, "This is not the shoulder I examined 3 weeks ago." What happened? Margaret told him about the morning move. He asked her to demonstrate it. She did. He watched. He said, "I know this technique. I have not been recommending it consistently enough." Margaret came to me 7 months ago, referred by her physical therapist, who had made meaningful but limited progress and who had been frank with her about the ceiling she was approaching with standard mobilization approaches. She was 72. Her frozen shoulder had begun insidiously, the way adhesive capsulitis almost always begins in adults over 60, not a specific injury, not a fall or a collision. A gradual onset of shoulder aching that she had initially attributed to sleeping on that side, then to arthritis, then, when it progressed despite her attempts to manage it, to something she finally presented to her physician 11 months into the process. Her physician had ordered an MRI, which showed no rotator cuff tear, no significant arthritis, no structural damage. The diagnosis was adhesive capsulitis, confirmed by the clinical examination pattern of globally restricted shoulder range of motion, with the capsular pattern of external rotation most restricted, followed by abduction, followed by internal rotation. She had received her first cortisone injection at the time of diagnosis. Significant pain reduction for approximately 6 weeks. The anti-inflammatory effect of the steroid reducing the synovial inflammation of the frozen shoulder's inflammatory phase, but range of motion had not recovered. The capsular adhesions were not dissolved by the cortisone. The inflammation was reduced. The structural restriction remained. A second injection at week 10. Diminishing returns. Less pain reduction. Shorter duration. Her physical therapist had begun gentle mobilization, passive glenohumeral joint mobilization using graded joint oscillation techniques. Range of motion had improved from its baseline of 60 degrees forward flexion to approximately 95 degrees. Meaningful progress. Then the progress had stalled. The stall at 95 degrees forward flexion is characteristic of a specific capsular restriction, the inferior capsule and axillary recess adhesions that are the primary structural barrier to the final arc of forward elevation. Standard mobilization techniques address the posterior and anterior capsule effectively. The inferior capsule, the most dependent portion of the joint capsule, the portion that must elongate most during full arm elevation, is mechanically less accessible to standard manual therapy because of its anatomical position. The loaded pendulum technique specifically targets the inferior capsule and axillary recess through gravity-assisted traction and rhythmic oscillation that creates intra-articular pressure cycling. This is why it produces progress where standard mobilization has stalled. I taught Margaret the technique. She performed it the next morning. She came back in 14 days. Understanding the capsular anatomy and the adhesive capsulitis mechanism is what makes the morning exercise's specific effects mechanistically coherent. The glenohumeral joint, the ball and socket joint of the shoulder, is enclosed by the shoulder joint capsule. This capsule is not a simple bag. It has specific anatomical regions: the superior capsule, the posterior capsule, the anterior capsule, and critically, the inferior capsule and the axillary recess, a fold of redundant capsule at the bottom of the joint that allows the arm to be raised above the head. When you elevate your arm fully, this axillary recess unfolds, elongating and allowing the humeral head to slide upward in the socket. In adhesive capsulitis, the joint capsule undergoes a fibroblastic transformation. Fibroblasts in the capsular tissue are stimulated by a mechanism that is not fully understood, but involves elevated inflammatory cytokines, elevated TGF-beta signaling, and possibly autonomic nervous system involvement, to produce abnormal type 3 collagen deposits throughout the capsule. These deposits create contracture. The capsule thickens, stiffens, and shrinks. The axillary recess, which should be a generous fold of redundant capsule, becomes contracted and adherent. The redundant fold disappears. Arm elevation is blocked by the contracted inferior capsule at whatever degree of elevation the remaining axillary recess allows. In adults over 70, 3 factors contribute to the accelerated fibroblastic transformation that produces frozen shoulder. First, elevated blood glucose, even at pre-diabetic or high normal levels, increases TGF-beta signaling in capsular fibroblasts, accelerating the fibrotic transformation. The association between diabetes and frozen shoulder is the strongest risk factor relationship in the adhesive capsulitis literature. Diabetic patients have up to 3 times the risk of frozen shoulder and slower resolution. Second, reduced tissue perfusion in the shoulder capsule from age-related microvascular changes impairs the resolution of the initial inflammatory phase, allowing the fibrotic phase to establish more aggressively. Third, hormonal changes, particularly estrogen reduction in postmenopausal women, reduce the anti-fibrotic activity in connective tissue, as estrogen normally suppresses TGF-beta-driven fibrosis. The loaded pendulum exercise does not reverse the fibroblastic transformation. No exercise does. What it does is mechanically distend the contracted capsule, specifically the inferior capsule and axillary recess, creating the controlled, sustained mechanical stress that signals to the capsular fibroblasts to remodel their collagen deposits. This process, mechanotransduction-driven capsular remodeling, is the biological mechanism of all capsular contracture rehabilitation. The pendulum technique delivers this mechanical signal more effectively to the inferior capsule than any other exercise because of its use of gravitational traction and rhythmic oscillation to create intra-articular pressure cycling. The loaded pendulum, specifically the technique that produces rapid inferior capsular distension rather than the passive pendulum that produces modest results over months. The exercise is performed from a bent forward position. You will need a sturdy table or the back of a heavy chair, any stable surface at approximately hip height. Starting position: stand beside the table, bend forward at the waist until your torso is approximately parallel to the floor. Support yourself with your non-affected arm on the table, placed flat on the surface, supporting your weight through that arm. Your affected arm hangs freely, completely limp, completely relaxed, directly below your shoulder joint. Your feet are approximately shoulder width apart. This starting position creates several therapeutic conditions simultaneously. The forward bent posture uses gravity to create gentle traction on the glenohumeral joint. The weight of the hanging arm distracts the humeral head slightly downward in the glenoid socket, decompressing the joint and opening space in the inferior capsule. The complete relaxation of the affected arm, which requires conscious effort because the shoulder muscles tend to guard, allows the full weight of the arm to create this traction without muscular resistance. The movement, the loaded oscillation. From this hanging position, you begin moving your body in small, controlled circles, not moving your arm consciously, moving your body, the torso, in small, slow circles, which causes the hanging arm to swing in a pendulum arc as a passive consequence of your body movement. This is the critical distinction from the standard pendulum that most physical therapists teach, where patients actively swing their arm. Active arm swinging recruits the shoulder musculature, reduces the traction force, and shifts the mechanical effect from the capsule to the rotator cuff. Passive pendulum, driven by body movement while the arm hangs completely limp, maintains the gravitational traction throughout the movement and applies the mechanical oscillation to the capsule rather than the muscles. The circle should be approximately the size of a dinner plate, small enough that the arm movement is controlled and within the pain-free range, large enough that the capsular oscillation is therapeutically significant. If the movement produces sharp pain, the circle is too large. Reduce the size until the movement is within the comfortable range. You perform 3 phases of circles. Phase 1, clockwise circles, 20 slow circles. The arm hangs and swings in a clockwise arc as your body moves. Count 20. The rhythm should be approximately 2 seconds per circle. Not fast, not slow. Phase 2, counterclockwise circles, 20 slow circles in the opposite direction. Phase 3, front to back pendulum. From the same hanging position, you move your body forward and back rather than in circles. The arm swings forward and back like a pendulum. 20 repetitions. After the pendulum phases, remain in the bent forward position and add the distension hold. At the end of the forward swing, when the arm is at the furthest point of the forward arc, pause for 3 seconds before allowing it to swing back. This 3-second pause at maximum forward displacement creates a sustained traction moment on the inferior capsule. The axillary recess is at its maximum distension point during forward arm displacement from the hanging position. The 3-second hold allows the capsular fibroblasts to receive the sustained mechanical signal for remodeling. 20 repetitions of the pendulum with 3-second forward holds. Then stand up slowly. Do not rush the transition from bent forward to upright. The joint has been mechanically stressed and needs a moment to redistribute the synovial fluid that the exercise has been moving through the joint space. Immediately after standing, perform 10 slow circles of the shoulder in the forward direction, then 10 in the backward direction at your maximum comfortable range. This active range of motion reinforcement after the passive pendulum consolidates the capsular distension that the pendulum created by moving the shoulder through the newly available range before the capsule has opportunity to resettle. Total time, approximately 4 minutes for the complete sequence. Perform this every morning before breakfast, before coffee, before any other shoulder activity. The morning timing is critical. Overnight immobility has allowed the capsular tissue to contract to its minimum length. The morning exercise at maximum capsular contraction produces greater distension force than the same exercise later in the day when the shoulder has partially warmed up. I want to explain the specific mechanism by which cortisone injections, the most commonly offered treatment for frozen shoulder, fail to address the underlying capsular contracture and may actually impede the remodeling process that the morning exercise is trying to accelerate. Cortisone and all corticosteroid injections reduce inflammation through glucocorticoid receptor signaling. In frozen shoulder, the inflammatory phase of the condition, which occurs in the first months before the fibrotic contracture is established, responds to cortisone with significant pain reduction. This is the clinical basis for the injections. Reduce the pain of the inflammatory phase, and allow the patient to participate in physical therapy. What cortisone does not do, and what the research on frozen shoulder progression consistently demonstrates, is reduce the capsular fibrosis. The fibroblastic transformation that produces the contracted adherent capsule is driven by TGF-beta signaling. Cortisone suppresses some inflammatory pathways but does not suppress TGF-beta-driven fibrosis. In fact, some research suggests that repeated cortisone injections may promote TGF-beta signaling in adjacent connective tissue, potentially accelerating the fibrotic phase that follows the inflammatory phase. Additionally, cortisone suppresses the mechanotransduction response in fibroblasts, the mechanical signal that the pendulum exercise is delivering to the capsular fibroblasts, Telling them to remodel their collagen deposits into a more compliant structure requires normal fibroblast mechanosensitivity. Fibroblasts exposed to corticosteroids have reduced mechanosensitivity. Their response to mechanical stress is blunted. The capsular remodeling that the morning exercise drives is less effective in a capsule that has recently received cortisone. Margaret received her second cortisone injection 10 weeks into her frozen shoulder. Her range of motion progress stalled shortly after, which she and her physician attributed to the natural plateau of the condition. It may have partly reflected the cortisone-induced blunting of the mechanotransduction response that her physical therapy mobilization was trying to drive. When I saw Margaret, 4 months after her last cortisone injection, the mechanosensitivity of her capsular fibroblasts had recovered. The loaded pendulum was working in a capsule whose fibroblasts were fully responsive to mechanical stimulation. The rapid response, measurable improvement by day 4, near full range by day 14, reflected this recovered mechanosensitivity in the context of a highly targeted mechanical intervention. If you have recently received a cortisone injection within the past 8 weeks, the mechanical response to the pendulum exercise may be slower than for someone who has not. This does not mean the exercise will not work. It means the timeline may be extended. 14 days may become 21. The mechanism operates regardless. The cortisone effect wanes. The mechanosensitivity recovers. The exercise then produces the response that the capsular fibroblasts are fully capable of producing. Margaret kept her diary with the careful attention of someone who had been told for 11 months that nothing would help and who wanted precise evidence that something was. Baseline. Forward flexion. 60 degrees. Measured with a goniometer her physical therapist had lent her. External rotation. 10 degrees. Internal rotation. Hand to hip only. Unable to reach the spine. Pain at rest, 4 out of 10. Pain with movement at end range, 7 out of 10. Night pain, present, waking her 2 to 3 times per week. Day 1. Margaret performed the exercise for the first time. She noted, the forward bent position feels strange. The arm hanging feels wrong. I kept wanting to hold it up. She focused on the conscious relaxation of the shoulder. She completed all 3 phases and the distension holds. She noted, after the exercise, when I straightened up and did the active circles, I could feel the shoulder had slightly more range. Not dramatic, real. Day 2. Day. Baseline flexion range before the morning exercise, 60 degrees. After the exercise, she checked by attempting to lift her arm, approximately 68 degrees. She noted 8 degrees more after the exercise. The acute distension effect is real. Whether it accumulates day over day is what matters. Day 3. Morning range before exercise, 65 degrees, 5 degrees above her absolute baseline, the first morning-to-morning baseline improvement. After exercise, 72 degrees. She wrote, the baseline is moving, not just the post-exercise range. The starting point before I even do anything is better than yesterday. Day 4. Margaret attempted to place her affected hand on her opposite shoulder, a movement requiring approximately 90 degrees of forward flexion and partial external rotation. She did it, not comfortably, not painlessly, but she placed her hand on the opposite shoulder. She had not been able to do this in 4 months. She wrote, opposite shoulder today, cried a bit. Day 7, forward flexion, approximately 120 degrees. Margaret could reach the kitchen cabinet at eye level. She wrote, opened the cabinet today, just opened it. Did not think about it until my hand was already there. Day 9. Internal rotation, hand to mid-back. She could reach the middle of her back with the affected arm behind her. The movement required for fastening a bra, tucking in a shirt. The 100 small daily tasks that internal rotation behind the back enables. She had not done this in 8 months. She wrote, reached my own back. I cannot describe how ordinary this is and how it made me feel. Day 12. Night pain. Absent. Margaret noted she had slept on the affected side, something she had not attempted in 7 months, and had woken with mild soreness but no acute pain. She wrote, slept on it, woke up sore but not in pain. These are not the same thing. Day 14. Orthopedic surgeon appointment, scheduled 3 weeks prior as a standard follow-up. The surgeon measured her range of motion with a clinical goniometer. Forward flexion, 175 degrees. External rotation, 40 degrees. He compared to his chart notes from 3 weeks prior. He said, this is not the shoulder I examined 3 weeks ago. What happened? Margaret demonstrated the pendulum exercise in the examination room. The surgeon watched. He said, "I know this technique. I have not been recommending it consistently enough." He paused. Then he said, "You should not need surgery." Margaret had been quietly considering whether she might eventually need a procedure called manipulation under anesthesia, a surgical procedure where the frozen shoulder is forcibly mobilized while the patient is unconscious, tearing the adhesions. She had been managing a quiet fear about this possibility for months. The surgeon's statement, "You should not need surgery," was the information she had been hoping for 11 months to hear. The sleeping position that is recontracting your shoulder capsule every night while the morning exercise is trying to expand it, and that compounds the frozen shoulder process by creating the mechanical environment most hostile to capsular remodeling, sleeping on the affected shoulder. This seems obvious. Sleeping on a painful shoulder is uncomfortable, and most people instinctively avoid it. But the problem is not sleeping directly on the shoulder. The problem is sleeping in any position that allows the affected arm to rest in internal rotation and adduction, the position of maximum capsular shortening. When you sleep on your back with your arms at your sides, the affected shoulder rests in internal rotation and adduction. The arm lies flat beside the body. In this position, the anterior capsule and the inferior capsule are at their shortest length. 6 to 8 hours of overnight maintenance at shortest capsular length produces the maximum morning capsular contraction that the pendulum exercise must work against each day. When you sleep on your non-affected side, which most frozen shoulder patients correctly choose as more comfortable, the affected arm typically falls across the body in adduction. Same problem, internal rotation and adduction positioning maintained for hours. The therapeutic sleeping position for frozen shoulder, which reduces the overnight capsular shortening that the morning exercise must reverse, is side-lying on the non-affected side, with the affected arm positioned in front of the body, supported by a pillow, with the shoulder in approximately 30 degrees of forward flexion and the elbow bent to 90 degrees. This position keeps the inferior capsule and axillary recess in a partially elongated position throughout the night, reducing the morning contraction that the pendulum must overcome. Margaret had been sleeping on her back with her arms at her sides. Her affected shoulder was in internal rotation and adduction for 7 to 8 hours every night. Every morning, the pendulum was working against the maximum capsular shortening produced by the overnight position. On day 5, I adjusted her sleeping position to the supported side lying described above. She used a standard bed pillow placed in front of her body with her affected forearm resting on it in the elongated position. The transition required a few nights of conscious position maintenance. She would wake having rolled, readjust, and return to sleep. From day 5 onward, the morning pendulum was working against less overnight shortening. The morning-to-morning baseline range improvement accelerated after day 5. The gap between successive mornings' baseline measurements widened in the second week compared to the first. Margaret noted the acceleration, but did not connect it to the sleeping position change until I explained it at her follow-up. The sleeping position change contributed to the full range of motion at day 14. Without it, full range might have been achieved at day 21. The pendulum is the exercise. The sleeping position is the overnight maintenance condition that determines how much ground the exercise must recover each morning before it can make new progress. Margaret's surgeon said, "You should not need surgery. 11 months of frozen shoulder. 2 cortisone injections that reduced pain without restoring range. 6 weeks of standard physical therapy that improved from 60 to 95 degrees and stalled. 14 days of a 4-minute morning pendulum exercise from a bent forward position. Full range of motion. Your frozen shoulder is not permanent. The adhesive capsulitis process that has contracted your capsule is driven by fibroblasts that respond to mechanical signals. The right mechanical signal, targeted, consistent, specific to the inferior capsule that limits arm elevation, produces capsular remodeling that restores range of motion faster than waiting for spontaneous resolution. 4 minutes. Every morning. Before coffee. Bent forward over a table. Hanging arm. Body-driven circles. 3-second forward holds. Active circles to consolidate. Side-lying sleep with pillow support. 14 days. Measure your arm elevation today. Note where it stops. Come back in 14 days with the new number. Leave a comment below right now. Tell me your age, which shoulder is affected, and how long the frozen shoulder has been present. I read every single comment. Everyone. Before I go, one request. Tell me your age and your #1 health challenge. I read every comment. Your comment might be exactly what someone else needs to see today. Subscribe. Tomorrow I have something just as important. I will see you then.